So what we've entitled this is the epidemiology, how the virus has affected people in BC, and there's several different aspects of this that I will run through with you. This is something that you've seen before. This is what we call our epidemic curve. So this is the number of new cases per day, and how this is plotted is by the date of onset of their illness. So this is after the public health investigation, where we talk to people about when and where they may have been exposed and when their symptoms start. And as you can see, since we put our control measures in, that's those dotted lines, in March, we have had a dramatic and sustained decrease in numbers of new cases. We have had, of course, some of the clusters that you're familiar with the outbreaks that we've seen. This also gives us a sense of where people have acquired their illness. The yellow bars are the ones where we are still doing the investigation, but as you can see, most of them is known from links to local acquisition. So that is our community spread, and that is what we're watching very carefully in the coming weeks and months. As we have said as well, there's every area of BC has been affected, and every community has been affected, whether they've had lab-confirmed cases or whether we've had people who've returned from travel, who've been involved or connected to outbreaks and clusters in other countries, on cruise ships or around the world, or here in BC. Every community in our province has had some brush with COVID-19. This is a group of slides, a group of figures that paint the picture of who is being most affected by COVID-19 in our province. And what it shows is men and women in the different age groups. And in the one slide, and let's see if I have a pointer here. There. Oh, I don't. Okay. At the top right, no, I guess it's top. The top right, I guess. Yeah, the one that says case counts %. What you can see is that most of the people who have been affected, so that's people who've tested positive for COVID-19, most of them have been between the ages of 30 and 60. And there's been more women than men affected. So the lighter pink bars are women and the darker pink bars are males. So what we can see from that is that most of the people who have been sick with this illness are people between the ages of 30 and 60. If we go over to the one directly below, the one that says case counts, to the percentage of hospitalizations, what we see is a shift to the older age groups. So those people who have severe enough illness to need to be in hospital tend to be older, mostly people in their 70s, 80s, and even 90s. And if we look at the difference in the pink bars, as we get older, we start to see that men more than women have more severe illness that require them to be hospitalized. If we go to the top right or top left here, on the screen, these are the numbers of people and the percentage of males and females who are admitted to ICU. So those are people who need more advanced care. Many of them require ventilatory care. And again, what we can see is there's a shift to older age group again. So this is just breaking down some of the information that we presented 2 weeks ago that shows that most of the people in ICU are in their 60s and 70s. And again, more men than women required that critical care. I will also point out, though, that younger people are not immune, and we are seeing people as young as 20s and 30s who require hospitalization and also who've been in the intensive care unit. Finally, on the bottom slide here, we have the same information by the number of people who have died. And again, we can see there's very much a shift to the older age group. The majority of people who've died have been people in their 70s, 80s, and over 90. We also have seen that it's much more that half of men over age 90 have died, whereas it's less than 20% of women. So this is a phenomenon that we're seeing around the world, that men are more likely to have more severe illness, to require hospitalization, and to die from COVID-19. And we really don't understand why. There's a lot of work going into trying to understand that phenomenon. Next, this is some information about healthcare workers, and we've been asked that question, how many healthcare workers have been affected? And so this is all healthcare workers as of April 28th. And so what we're talking about is anybody who's one of the regulated health professions, so that includes dentists, dental assistants, for example, as well as nurses, physicians, physiotherapists, others, care workers in our healthcare system. So many of these people were affected at work, either from a colleague or from acquiring this from caring for patients with COVID-19. But it also includes people whose exposures may have been through travel themselves, through attendance at, for example, the dental conference that we know about, or from exposure to family members who may be positive for COVID-19. So what we can see is 21% of our total cases as of April 28th, or 428 people, were healthcare workers across the province. But thankfully, a very small proportion of them, only 8%, were hospitalized, 3% required intensive care. And unfortunately, we had one person who died. So this tells us that most of our healthcare workers, thankfully, were in the younger age group and were mostly younger and female and did very well and and had milder illness. One of the other things that we've been looking at very carefully is what are the things, the risk factors that people have that make it more likely that they will end up with more severe illness. And this information that I've provided here, and we've got two slides that show it, is the information that we have complete records for. So it's not the entire group of people, the 2,000 and so people who have tested positive yet, because it takes some time before we know that people end up in hospital or their outcomes. But this is the complete data as of April 30th, and of those of the people that are presented here, 1,373 reported one or more of these additional risk factors that make it more likely that they'll have more severe disease. What we can see is that of all cases, being over the age of 50, about 56% of all cases, and this goes back to what I was saying, where it's mostly a younger age group, but of those admitted to hospital or into intensive care, 80% of those people were over age 50, and a very high proportion, 97% of people who died were over age 50. And we know that the majority of them were in their 70s or 80s. The second line talks about male versus female, and this is similar to the information I just presented, where about 44% of all of our cases are male, but they're 2/3 of our cases who end up in hospital or intensive care were male, and almost 3/4 of our deaths were in men. Finally, we look at chronic conditions, which means things like diabetes or underlying heart disease or lung disease that make you more likely to have severe illness. And we can see that about a third, a little over a third, almost 37% of all cases, everybody who was diagnosed, had at least one chronic condition. But you were much more likely to end up in hospital. About 2/3 of people who ended up in hospital had at least one chronic condition, and 3/4 again of people who required ICU care, and 83% of people who died had underlying illness as well as a risk factor. Again, this is the same information, just presented so that you can see the progression of these risk factors and the impact on the severity of illness. One of the other outcomes that we are looking at is how well people do once they have been in critical care. So overall, as of the time that we put these numbers together, up till April 29th, we had 199 individuals who required critical care. And of those, 28 people died. So that's 14%. Which is, of course, a very high number. And we can see from what we just presented that these are mainly men over the age of 50 who've had underlying conditions. On a positive note, 110 of the 199 people have been released from hospital and have recovered, and a number in between are still in the recovery. The next slide just presents a graphic of the number of people in ICU per day per health authority, so you can get an understanding of how it's affected the different geographical areas. As we can see, most of the people requiring critical care have been in Fraser Health and Vancouver Coastal, and as we know in our pandemic, that's where the majority of people who have been affected have been. So last week we talked a little bit about looking at excess deaths, and there was a modeling study done in Ontario that considered the impact of the pandemic on the population. And I reported that this is a measure that we look at here in BC on an ongoing basis. And we have, on average, all-cause mortality is a very stable measure in our community. And on most days of the year, about 115 people die in British Columbia from a whole variety of causes, whether it's old age or motor vehicle crashes, overdoses, the other impacts that we have in our community. And we have been following the impact of COVID-19 on that measure over time. This is something that we have been doing for a number of years through the BC CDC. For example, when we had the forest fires of 2017 and the summers of 2018, we had very poor air quality for a number of weeks. And we saw the mortality, the all-cause mortality, in excess of normal for several weeks afterwards. This graph gives you some indication of what we've seen in the last few months with the impact of COVID-19. We have had about 170 excess deaths since March, and the vast majority of them, at least 111 that we know of so far, have been attributed to COVID-19. So that does give us a measure that this outbreak has had a population effect. What we don't know is what else is causing these excess deaths during that period of time. And what we get is more detailed information from the vital statistics, from the death certificates over time, and we will be able to look back. We get the ones for March at the end of this month, and then we'll be able to look back and find out what were the other contributing factors to the excess deaths that we've been seeing here. And we think it's very likely some of them will be indirectly related to COVID-19. There may also be causes, for example, we know that people were not going to the emergency department because of concerns about COVID-19, and it may be that there was excess deaths that were recorded from that. So we will, once we have that information, be able to provide it to you as well. So the case rates, these are slides that are just an update of ones that you've seen before. This shows our rates per million population in British Columbia compared to the rest of Canada and to a number of other countries. And as you can see, this is the work that we have all been doing over the past few weeks in what we've called bending the curve and now flattening it. In addition, this is an update of the death rates by countries here in BC, the rest of Canada, and a number of other countries, showing again that we have leveled off, and of course that it reflects the numbers of deaths that we've had, unfortunately, in long-term care homes in our elderly. All right, next I'm going to turn it over to Minister Dix, and we're going to give you a little bit of an update on some of our critical care.
Thank you very much, Dr. Henry. And what we're going to look at here is our provincial bed capacity in critical care, and you see it up here now. We have reduced some of our surge capacity since the last time we updated you, from 951 to 704 critical care beds. Nonetheless, we currently have a critical care bed occupancy rate of about 44%, so 390 total vacant critical care beds. You see in the two categories there that we have 30 people as of this graph's information, which was May 1st. 30 people in critical care for COVID-19. Dr. Henry's just updated that to 20 as of today, May the 4th. So that's what's in critical care. And then there's 284 people who are in critical care for non-COVID-19 cases. So to move on to ventilator capacity, again, as you can tell from when we started or where we started in March, we've significantly increased our ventilator capacity. And you see that in addition to that, we have portable ventilators and an intention to increase the ventilator capacity of the province in the coming months to deal with the potential for future surges. It should also be pointed out that the Premier a couple of weeks ago announced our plan to add ambulance and transportation capacity to bring people, especially from rural and remote areas, closer to critical care. And just if you go on from there, this is the use of mechanical ventilators in critical care as of now. So you see on the top row that as of April the 30th, there were 112 people on mechanical ventilation at that time, 17 of them at that time, so it's a subset of those in critical care were on mechanical ventilators on April the 30th. That total as of today, the updated total is 9 for COVID-19. So you see that we are well within our capacity for mechanical ventilators. So just to be very brief about this is an updating of what we presented to you a few 2 weeks ago, that we've remained ready, obviously, for critical care patients, including those with COVID-19, that the number of patients with COVID-19 has slowly decreased over time, as we've seen, reflecting also the reduction in hospitalization. We regularly report on the number of vacant beds overall in the healthcare system, which today will be 4,075. What that has permitted us to do is to prepare and be prepared for COVID-19 surges in the healthcare system, and also, most importantly, protect and support healthcare workers, be they doctors, be they nurses, be they healthcare workers or health sciences professionals. And also, we have additional adult-capable critical care ventilators have come into the inventory, as have additional adult portable ventilators, which can easily be moved between sites or with patients. Additional adult ventilators are expected to arrive in the weeks and months to follow, and we will keep you updated on those numbers. And I'm going to return it back to Dr. Henry.
Thank you. So for the next part, what we wanted to do was give you an update of where we were, who's been affected, and as you can see, it's had an impact, quite a dramatic impact on our entire population, differentially affecting those who are older, but also very much affecting younger people, and particularly younger people who have underlying illnesses. We also have a significant proportion of our cases who are healthcare workers. And this is what what we've accomplished here in BC has been able to protect everybody and ensure that they had the best chance at getting the care they needed. So where we need to move from here, here's where we are at the point where we have deflected our curve. We're coming down nicely. We have the measures in place that we know are working. And how can we use modeling and the work that we've been doing over the past months to understand where we need to go in the coming weeks? And so this is an update of the slide we presented a little over 2 weeks ago that gives you a sense of some of the modeling that we're using to inform our decisions. So what this shows is the ventilator capacity, the critical care patient census, so the number of people in critical care up until the end of April, that's the yellow bars. And then these lines give us a sense of what would happen should we let up the restrictions that we've put in place too soon, too quickly, or too much. And that is the work that we are now looking at to guide our way forward. So this is what we call the compartmental modeling that we've been doing, the dynamic modeling. It looks kind of weird, I guess, in 2D. But what it does is it takes into account what is exactly has happened in our community. It looks at the types and numbers of interactions that we have in our community. It looks at how that has affected our pandemic, and we've been tracking our cases, both in the cases in the community, as well as cases diagnosed in the community, as well as those in hospital and those in ICU. And this helps us understand where we fit There were a number of different models that we were looking at, and this is the one with the best fit to what has happened to us. And it allows us to say, okay, these are the things that changed over time, and here's where we are now. What are the scenarios that we could see happening if we change some of the parameters going forward? So just to explain this a little bit more, the dark pink line in the middle is the smoothing or the average of what has happened in our pandemic over the past 2 months. And those lines with the dots are the actual case counts per day. As you can see, we had a dramatic increase in March. When we started to put in our measures, we were still seeing cases go up, and that's because we know the incubation period is 2 weeks. So when we first started to do our physical distancing and our staying at home and our closing up of a number of areas where we gathered and people working from home, all of those measures meant that we started to see a decrease in new cases after 2 weeks. We had a bit of a blip, as we know, a couple of weeks ago that was related to both opening up our testing so that we were testing more people again, but also the outbreaks that we've had in our community that we've recognized. And it really is a cautious tale. When we looked at the poultry industry, the poultry manufacturing, and recognized that there was transmission going there that was unrecognized, and that we needed to be sure to be able to safely open other places and to continue to provide those essential services, that we had the right things in place. So this is where we are now with the distancing that we've done, and I showed you before that we have our physical distancing and the staying and working from home and schooling from home has brought us to about 30% of our usual contacts in the community. And the next series of slides gives us some sense of what might happen once we start to loosen those restrictions, whether we have more contacts and what type of contacts they are. So there's 2 ways that we can look at this. One is what can happen if we have more unprotected contacts with more people, and the second is how can we manage that by having increased numbers of contacts but in a safe way. So the first graph tells us if we increase our contacts from where we are now to about 40%, we would expect that our new cases will continue to be relatively low over the coming weeks and months. And our hospitalizations would similarly stay relatively low, because we know only a portion of people who get sick with this virus need to be in hospital. The second in the middle, second set of graphs tell us what could happen if we increase our number of contacts by from basically double what we are now, from 30% to about 60%. And again, that shows us that we might have increased numbers of cases and some hospitalizations over time in the coming weeks, but they would be manageable. We would be able to continue to have the surge in our community to be able to manage that. And there are things that we can do that make these types of contacts, the increased numbers of contacts, safer for people as well. Finally, on the 80%, that means if we go back to December, where we were having lots of gatherings, where people met, where this virus has the opportunity to take off quite rapidly, we could expect to see just that the more potential for transmission between people means that the virus will be able to increase exponentially, and we might be in a situation that we've seen in other places around the world where we have a rapidly increasing outbreak, rapidly increased number of people who need hospitalization. So our challenge and our work together is to find that sweet spot, somewhere around, increasing our contacts by at least half or twice as many as we have now, but without allowing those opportunities for rapidly exponential growth of the virus in our communities. So that is what we are basing our goals on for going forward. We must find that right balance to protect lives by suppressing transmission to the lowest rate possible, particularly to try and protect those who are more likely to have severe illness, to end up in hospital, or to die from this disease. We need to ensure that our health system continues to have the capacity to offer the care that we need, both for COVID-19, but also for all of those other health issues that we have in BC. We need to meet, of course, the physical and mental health challenges that come with the social restrictions that we've had in the last few months. And that is important as well. We know that our mental health, our economic health, affects our overall health and our population as well. We need to rebuild our resilient economy and provide supports for people so they can safely return to work. And we need to strengthen our social fabric. It is important for us to have connections, both with our households and our families and our more extended families. But we need to do that now in a controlled way, in a managed way, and in a safe way. One of the models that we're using, or frameworks that we're using to help underpin our way forward, is what we call the hierarchy of controls. And this comes from the infection prevention and control world in healthcare and other worlds, and other realms as well. What this is, it looks at what are the most effective ways of preventing transmission of this virus. There are things that we know work and work well. Physical distancing, it has made a difference. It has allowed us to put the brakes on COVID-19, but we haven't stopped the car, and it's very unlikely that we're going to be able to, at least in the coming months. There's so much that we actually don't yet know about this virus. And this is not just us here in BC or in Canada, it's around the world. And we're looking at this in great detail. We're watching what's happening in other countries. But until we have a vaccine, we know it's going to be here in some way. And our job, our role, our goals in the next months is to make sure that we learn how to live with this virus in a safe way that protects people. This year, maybe that with so much unknown, is going to be unusual. We don't know yet whether we're going to have a resurgence of respiratory illness when influenza season and respiratory virus season starts again in the fall. That is something we need to plan for, we need to prepare for, and we need to monitor for starting now. The other things that we need to think about is engineering control. So those are things like the physical barriers that we see, the plexiglass that's put up, that helps us have, when you can't keep your distance, making sure that you can have that contact with somebody in a safe way. And then we talk about things like administrative control. So that would be reducing the number of people that are in a building, putting those markers on the floor so that you follow one-way traffic instead of going back and forth and crossing over. And things, incredibly important things, like making sure we have policies that mean people who have illness do not go to work and are not penalized for that, and do not go to school. And then finally, the least effective measures that we have, that we do need to use in some situations, are things like personal protective equipment. And those are the things that we need to think about in our communities in the coming months. You know, what is the role for things like wearing non-medical masks in certain situations? So this is it. For our key principles for going forward are staying informed. And we are committed to providing you with the best information that we can, following the advice that we have. Practicing good hygiene, so the hand hygiene, the avoiding touching our face, the coughing into our sleeve, covering our cough, disinfecting frequently touched surfaces, those are all things that are needed and need to stay the same. Staying at home and away from others if you're feeling ill, that has to be our new normal forever. But really important in the coming days and months is how we make sure that this can happen in all of our lives and in all of our businesses, in all of our recreation and schooling, in every setting that we have. We recognize that this social interaction and connecting with close family and friends is important for all of us. It's critical for all of us. But to safely increase our interactions, there are a few important things we need to remember. First, the more people we interact with, the higher the likelihood that we'll be exposed to somebody who might be carrying COVID-19. Second, we need to think about who in our household may be at higher risk and need more protection. And that could be somebody who has underlying illness, somebody who's elder, somebody who's going through cancer treatments. And if we have a family member who's at high risk of severe illness, we need to consider the less interaction we have with others outside of our family. And reconnecting with even one additional person outside of our family or beyond our household or our bubble, our pandemic bubble, is a bigger connection than we may realize. One additional ring can make for a much bigger tree if we think about rings in a tree. When you invite one person outside of your immediate household bubble into your home, you're also inviting all of the people in their bubble, the people that they've had contact with. And that includes people from their work, from their home, and others that they've had close contact with. So these physical distancing and how we manage those in the coming months is going to be really important. We're going to be working on increasing our environmental cleaning, considering, as I mentioned, the use of non-medical masks, and of course, we need to consider as well our non-essential travel and how we're going to manage that through the summer months. So this is, I believe, the end of our beginning of this pandemic. We do not yet know what's going to happen, but we know that we have some room to increase our social connections, to increase our work, to increase our school and daycare and childcare. But as we start this new phase, we need to keep those principles in mind. They are the playbook for all of us to follow. And the Premier, as Minister mentioned, will be speaking this week to how government will be moving forward using these principles and a plan. What you can be doing now is use these principles we've shared today and think about how they affect you in your personal go-forward plan. Until we have all of the pieces in place, though, it's very important that we continue to do what we do right now because we know it's working and it's saving lives in our families and our communities. We need to continue to be measured and thoughtful on the circumstances based on what we are seeing with our pandemic here in BC. We all want to keep our province safe and to create the opportunities to connect more and to get our businesses going. We also know that nobody wants to return to having a rising curve of new cases or tragic deaths. It is our curve, and we can continue to push it down and keep it there. It is in our hands, as long as we don't forget to wash them. So let's keep this going, and let's keep with what we have been doing so far, which is being kind to each other, being calm, and staying safe.